Hello and welcome, everyone. We are thrilled. We're going to go ahead and get started in the interest of time. I know everybody's still eating their lunch. Thank you all so much for being here. We're thrilled to have you. My name's Juliana Bailey, and I'm a senior dietitian at Alfred Health in Melbourne, Victoria. And this is Dr. Jessica Alvarez, who is my lovely co-moderator. She is an associate professor at Emory University. And I have the great pleasure of also introducing Stephanie Foligno, who's going to be our first speaker. We just wanted to start off by giving our session objectives today. We want to describe emerging nutrition research for children and adults with CF and explore how highly effective CFTR modulators are changing patient perspectives on nutrition status. And finally, we hope to have a little bit of discussion around ideas generated for implications for clinical practice and potential for future nutrition research. And I also have a shameless plug from the program planning committee here. I have a QR code that I would like everybody to scan and fill out after the session is done. We would like your feedback in how to best go forward with our nutrition conference planning. It's a survey on topics, and if you would like to be a speaker or if you have a wonderful session idea, this is where we'd like to hear from you. So we'll save that until the end. And without further ado, there we go. Perfect. So it's my great pleasure to introduce Dr. Stephanie Foligno. She is a psychologist at Cincinnati Children's Hospital and Medical Center, and she's also a professor of pediatrics at the University of Cincinnati College of Medicine and has a joint appointment with pulmonology. So without further ado, I'm going to let her come speak to you about her study.
Hi, everybody. I just love seeing a full room. It makes it so much more fun to be up here. And very, very thankful for the invitation and for all of us to be thinking through an area of our clinical service and our research lines that are really near and dear to our hearts. One of my roles as a psychologist is to really help people understand what we have yet to learn, where the gaps in our learning are to build skills. And so we're going to be talking a lot about that skill development and how we can help people be healthier and happier with their bodies. And here are my disclosures. So I kind of wanted to set the stage today to have us be thinking about, I loved the session title, right, having to do with navigation. So what are we navigating exactly? Well, we're navigating a lot of changes. There are changes in treatments with advancements that are having impact on treatment burden with, first, most people, not all, unfortunately, some reduced treatment burden. The treatment advances are having some positive impacts on quality of life overall, being better able to engage in role functioning and overall mental health and physical health. We're also navigating the changing aging population, the growing aging. Also, in the advent of utilization of telemedicine, our CF care delivery is also changing. We're also sort of navigating our people in general, including people with CF, more sedentary, and there is some pretty good evidence from the WHO that 81% of adolescents were insufficiently active relative to activity guidelines. Is our nutrition different? And we know that, part of our population is continuing to move into that overweight and obese health categories. So we have increased survival, increased weight and obesity rates. We're seeing improvements in FEV1. Oops, sorry. Okay. Layered on top of the things that are changing, we're also navigating things that have really stayed the same. We have a lot of variability in phenotypes, which means that we have lots of different approaches to individualizing care. And certainly in the area of health and nutrition, individualized care is really essential. We maintain our CF interdisciplinary team collaboration, which is really essential to have passionate, bright, dedicated people with different expertise at the table. That can also lead to some challenges, understandably, in communication and collaboration. And then there's variable nutrition in people's homes. You know, how much do they know about nutrition? What kind of skills do they have in the kitchen? What kind of skills do they have in terms of reading nutrition labels? How much time do they have to prepare healthy meals and snacks? And then what's the food availability? And certainly some of the really important work that's been done in CF around food insecurity demonstrates that we have, you know, somewhere between 2/3 of people who we really need to be concerned about. And that is not necessarily just for our lower income brackets. We also are navigating the age-old knowledge and truth that behavior change is extremely difficult. Not impossible, but difficult. Think about, is there anything else that we're navigating? So yeah, that's another part of the change, right? Is you had this mental model of how you optimize nutrition, what kind of nutrition is needed, and then kind of this pendulum is swinging. So we know that behavior change can happen, but boy, oh boy, does it need sufficient intensity and planned follow-up support. And that is to promote adherence to any intervention. The interventions that have been published to date demonstrate that gains may be small, but important, and that planned support is needed in order to maintain those gains, or those gains are oftentimes lost because those habits have not been sufficiently established. The U.S. Preventative Task Force review of interventions for high body mass index in kids and adolescents included 28 random controlled trials. And they found that there was a small reduction in BMI after a pretty intensive duration of intervention, and that their larger effects were found when there were more contact hours and physical activity components were included in the treatment. And why I think this is really important for us to think about is how do we feasibly do some of these interventions in our clinic? And then I've been involved in a few behavior nutrition treatments in CF that were family focused for our young kids. And again, this is just to demonstrate that we had an 18-session protocol that include clinic and home-based interventions, and we saw a greater decrease in BMI-Z for these young kids compared to less intensive interventions, still very intense. Also, we had one in CF specifically that was looking to increase calorie intake versus the other 2017 study that was trying to reduce calorie intake. And that involved 12 visits weekly for 8 weeks, and then we were seeing them monthly for 4 months. And we were able to see improvements in calories compared to control group, and they had gained some weight as well. But boy, oh boy, pretty intensive interventions. So what do we know about body composition? So we do see that positive association with FEV1 and fat-free mass, inversely associated with fat mass. There's this impact with modulator therapies with fat mass and percent body mass, but not skeletal muscle mass nor strength. Practice guidelines include recommendations for body composition assessment, but how feasible is that? And this is the discussion we can have today. We know that it needs to be individualized and that it needs to include a holistic health approach with evidence-based recommendations. So let's pivot a little bit to talking about how we've designed our pilot study. We were really thoughtful about designing a study that would fill families' needs. Like, what do families want around building body strength? What can families actually do to change their behaviors and their habits? What can we deliver based on our interdisciplinary team training? How logistically will we deliver it? Who's going to actually deliver the components of the intervention? Will it be impactful? And will it be feasible? And one thing that we absolutely learned, that even for a smaller pilot study, this was a very complex protocol that we were able to implement. So our inclusion criteria were determined by our clinical and research teams, and we were really prioritizing clinical feasibility. So the youth were greater than the 59th percentile BMI with a positive Z-score fat mass index and negative Z-score fat-free mass index. Our interdisciplinary group developed the protocol for education and intervention components. So that included our absolutely essential and fantastically smart and skilled dietitians, our exercise physiologist, and myself, along with Dr. Boat, who was the PI of the study. And then we were working together to determine our outcome metrics in terms of dietary intake and BMI. And then we were looking at specifically muscle strength and exercise capacity for our body composition assessments. We took a really thoughtful approach to really looking at the ethics and building a respectful approach to enrollment, given the sensitivity of this information and our study procedures. So I worked with our research coordinator and coached her in her recruitment, using a script for phone calls, using a weight neutral and destigmatizing approach. And this is a really skilled research coordinator and was insightful enough to say, I really need this because I want to do this right. So we were, really proactive with that approach. And then we developed our protocol again with the lens towards feasibility and acceptability, meaning we don't want to have too many visits. We added a telehealth group option so that families didn't have to travel to their groups with me. We promoted and built in the social support within the group treatment. And then we had essential grant support that allowed us to purchase the equipment. And we needed a lot of study coordination to connect all of these dots and make sure we weren't having anything fall through the cracks. So we had 12 participants, mean age 10, but a pretty good range of our school-aged kids. You can see here pretty healthy in terms of BMI and FEV1. They had not had any hospitalizations in the 12 months prior to enrollment, nor during the study period. No one had CFRD. We had 3-day diet recalls with a registered dietitian to calculate total energy, macronutrients, and fiber. And we used the InBody 770 multi-frequency for our BIA. And then we used the Actigraph watch. And we just note here that this model has since been discontinued. We measured quad strength using the dynamometer, hand grip strength, and then we had baseline data that guided the initial recommendations, and we engaged in shared decision-making with our families regarding their initial nutrition and physical activity goals. And this is just a visual for you all to see what this 3-month intervention looked like in terms of when we collected diet information and that they received the behavioral session all 3 months, the exercise session in the first 2 months, and then we looked at Actigraph data. So in terms of the nutrition and exercise components, our dietitian, Kathy, reviewed the 3-day recall, identified initial family goals, provided really important education and support around health decisions with portion control, frequency of eating, strategies for limiting sugar-containing drinks, how to boost fruit and vegetable intake, limit fast food intake, eating outside of the home, how to optimize protein intake and healthy snacking. And families selected which of these treatment targets that they wanted to focus on. So Kathy was really doing the what that they wanted to do, and then I was coming in to support how they would implement that into their family functioning. And then Carla, our exercise physiologist, created some fantastic exercise, a booklet, as well as some videos, an exercise calendar, and then provided them with a set of dumbbells and a resistance band. Families were offered if they want to do 10 virtual exercise classes every 2 to 3 weeks that lasted about 45 minutes if they wanted to interact and do this as a family with her. I had an individual session with each of our families just to talk about confidentiality and how the groups would run, develop their action plan, and then I met with the families in a group session for 3 sessions, including parent and child when the child wanted to participate. So we're talking about what are some of the thoughts, feelings, and behaviors that impact your decision-making around nutrition and physical activity. We taught families how to set SMART goals. Many of our families simply had not done this before. Some of the kids had done it in school, but the parents hadn't all had exposure to that. And then we talked about how to limit screen time to CF treatment time in 1 more hour to then allow families to have some of that scheduled physical activity time. Talked about whole family health promotion, how they can plan together, how confidence importance changes over time and ambivalence changes, and self-monitoring as an essential behavior change skill and tool, and that sometimes we need to set smaller goals, build that behavioral momentum up before we make some of the harder changes. We revised goals as needed and then taught parents some behavior management strategies based on child behavior, perhaps some non-compliance and some resistance around eating what they're recommending and engaging in physical activity. So what you can see here is kind of a plot that shows you how interested families were. So we had an initial pool of 57. We had a hard time reaching about 19 of them. We had 14 declines, but we had over nearly half of families who accepted to enroll. And then our final study pool was 12. What I really want to pop out here for everyone is that we had 100% attendance to all the individualized sessions for me, and we had 100% attendance for all of our group sessions. Families came to the first one and they finished the other 3. We didn't see as much engagement with the virtual exercise sessions, but of course, families engaged with our dietitians as an essential part of the protocol. So they enrolled, they completed, but not anything extra. So what's our goal? Is kind of like weight stability, good enough for this age? Are we, looking at how do we promote strength? So in our small pilot with 12, we did not see any change in BMI, but a normative developmental increase in height and weight. We didn't see any change in muscle mass, fat mass, or quad strength. There was a trend for hand grip strength. And we used the walk test, and while there was no significant difference in the distance the kids walked, there was in their heart rate recovery 30 seconds post that shuttle walk. I will absolutely point out that our home adherence to the protocol was variable and in need of attention for some of our families. Don't want to eat what parents serve, don't want to wear the watch, don't want to lift weights. This study really did set the stage for increased awareness within our entire interdisciplinary team, and also for the families to say, how do we do this and where are you getting stuck? And then we're in the process of analyzing 6 and 9 month data when that comes in for sustainability. So we have to stay strong and stay committed to this, knowing that small changes is probably what we're going to see, even with highly intensive interventions. So we have to plan them smart, and we need to provide the proper follow-up support to promote adherence to whatever interventions we decide to do, whether that's a QI project in our center, or multi-center study in the future. Our interdisciplinary interventions are essential, and they can be complex. So we have to plan for where things might fail. We know that interventions are not for everyone. Not all families are going to be interested in this, but we can identify the families who are potentially most at risk and then use some of our motivational interviewing and PEP skills to support readiness for change. I know all of us are thinking through how we might integrate these individualized evidence-based interventions when available into our clinical care, so I hope we get to discuss that today. And how we'll all continue to balance feasibility with the intensity that we know is really needed for these behavior change interventions to be effective. So not only are we working towards effectiveness of these robust interventions, but we also need to plan for follow-up support. One of the questions that I've thought about is, could we incorporate some of this physical activity and nutrition behavior change pieces into the lifestyle module for CF Rise? That's one of the things that we've been thinking about in our center and maybe other places in transition programming as well. You probably know this, you've experienced it in any of the work that you've done if you've used actigraphy. Measuring the kids' physical activity was particularly challenging for the kids in this age range and multifaceted. So we learned a few things. One is that kids are not allowed to wear these actigraph watches during most of school-sponsored sports. So we're missing out on some really important physical activity data. These devices tend to malfunction. We have kids who don't want to wear it. And just also note the device that we used did not collect heart rate data, which is an essential part of categorizing physical activity in terms of mild, moderate, and vigorous. So I want to thank you all for attending. Of course, shout out to my collaborators and research team here, our CF team members who continue to really help us think through how we're going to be optimizing nutrition and physical activity, Vertex for the funding for this study, and then of course our families who teach us so very, very much. If you want to see some of the results of this pilot study, we have a poster 161 in the exhibition hall. So thank you.
Okay, we will go ahead and take one or two questions now, and then we'll take group questions after all of the talks have gone. So if you have any burning questions for Dr. Foligno, please step up or speak really loudly.
Yeah.
I have a question.
Yes.
What
Dr. Alvarez.
you said that your participants, your families could choose sort of what intervention they wanted to go for. Which ones were the favorites? What were the top interventions that they wanted to pursue?
Kathy, you correct me. Give me a thumbs up if I'm right. Optimizing protein, reducing sugar-fueled beverages, and increasing fruits and vegetables. Yes? Did I miss any? Okay. So yes, but let me preface this a little bit, because I think this is a really important question for us to be thinking through and incorporating into our clinical care and our interventions, whether they're in clinical or in the research realm, right? So we included that anticipatory guidance in our first group session with families. So we had already covered confidentiality when I met with them individually, but right out of the gates, when we met for that first group session, I set the stage to say, how did we get here, right? And one of the components of that conversation is part of why this is so confusing and mind-bending and hard is because you've actually overstudied for the test for so many years. And now we're saying, you don't have to study so hard, right? But you do need to make changes. And so we thoughtfully plugged that into that first group session because we're trying to help just have families understand we get this. We have these conversations in clinic, right? And we know that part of our messaging that was very well intended is now changing, right? And that change is actually good because people's health is not the same now in the era of ETI and other advancements in treatment. And so our messages are going to change. I mean, we hope so, right? One of the messages, sort of unrelated, but indirectly related, is are people doing as much airway clearance as they used to? Our messaging is changing. Why? It needs to change, thankfully, right? That's a good change. But even when it's a good change, we do want to validate that that is hard. It's hard emotionally. It's hard cognitively to like switch things around. And it's hard to exercise more. It's hard to eat differently, especially when you have kids who are really opinionated and they're developmentally afraid of trying new foods and all of the things that we build into these family-focused behavioral nutrition and interventions. Thank you for that question.
Thank you, Dr. Foligno. We'll hold off any additional questions until the end. We have seats in the front if anyone who's sitting in the back wants to come up to the table. And now I'd like to introduce Dr. Juliana Bailey. She's all the way in Australia right now. She's a senior dietitian at Alfred Health in Melbourne, Victoria, and can't wait to hear what you have to say.
We are. Thank you for that introduction, and thank you all for being here today. I'm going to talk to you all today about diet and body composition and the impact on drug absorption and response in CF. And this was a pilot and feasibility study. These are my disclosures. And I also wanted to start off this talk by acknowledging my co-principal investigator on this pilot grant, Dr. Jennifer Gimbalot. She is an associate professor of pediatrics and chief of the pulmonary medicine division at University of Arkansas Medical Sciences. Jennifer is an expert in pharmacokinetics and clinical pharmacology specific to CFTR modulators. So I am presenting some of her data today. Disclaimer, I am not an expert in clinical pharmacology, so I'm going to do the best I can with her data. She was too busy giving her 4 other talks on this topic at this conference. So if you have an interest in this, I highly suggest that you go to one of her other talks while you're here. So I think this is something that everybody in this room is aware of. Malnutrition in CF is declining. And this is a nice graphic from a study from the US CF Foundation Patient Registry. And we can see in the blue bubbles that across the past 2 decades, malnutrition has been declining. And happening in parallel with this, the rates of overweight and obesity are increasing. We all see this in our clinical practice as well. I like to show this graph because this was actually data from before CFT or before Trikafta. So that being said, we do think that rates of overweight and obesity are increased after modulators. We have some work from Dr. Gimbalot that shows that in both adults and children on ivacaftor at 5-year follow-up, the rates of overweight had increased, and in adults, the rates of obesity had increased. This was also seen with ETI and Marina Litvin's work in a single center of 134 adults with CF that examined some anthropometric measurements before and after treatment with ETI, and both overweight and obesity increased in this cohort as well. So there are probably many things driving this, but from a dietary aspect, we know that fat intake is increased with the use of ivacaftor. This is some work by Dr. Virginia Stallings and her group that compared Italians to North Americans and found a significant increase in fat intake on ivacaftor. This might be due to the fact that these are lipophilic drugs, they require fat for absorption, and the package insert counsels patients to take the drug with fat but doesn't specify an amount. This is some of our group's unpublished data that shows a similar trend with total fat intake increasing with long-term use of ETI. There was a mean increase of 20 grams of fat per day pre to 10 months post taking ETI. Again, we believe this has to do with the package instructions to take this drug with fat, and there is not evidence for exactly how much fat is needed to absorb it. So if you're like me, I've heard anecdotally from a lot of my patients that I have to take this modulator with 20 grams of fat or 15 grams of fat or some high amount of fat in order for it to be absorbed and be effective. And I think sometimes people have this idea that the more fat they take with it, the more efficacy they're going to get from the drug. And so that is sort of some anecdotal reporting that we've heard and word of mouth based on these product insert instructions. There are even a lot of educational handouts I've seen that said, you have to take your modulator with this specific amount of fat. We really don't know that, though. We don't know the right amount. So there is also this known food effect with the drug. And in some of Dr. Gimbelot's work from 2022, she had an incidental finding that showed a significant difference between the diet provided during the study that was higher in fat and concentrations of the modulator. So with all of this in mind, we hypothesized that people with CF might have changed their dietary intake in order to maximize their personal outcomes from ETI, and that effective plasma concentrations of ETI can be achieved using a healthy, fat-containing balanced diet. We had two aims in this pilot study. The first was to explore perspectives on dietary intake and weight status in the context of ETI therapy. And the second was to understand the impact of dietary practice on ETI concentration variability. So this busy slide is to describe our study design. We had 3 parts to this pilot study, and in the first part, we gave a survey to a single center with a goal of getting 100 responses. The survey was largely about nutrition-related knowledge and practices after starting modulators. I'm not going to go too in detail about the survey in this talk, but if you're interested, you can go to poster number 608, and this will also be presented in workshop 24 tomorrow morning at 10:15 a.m. I'm going to talk mostly today about part 2 and 3 of our study, which was the pilot and feasibility arm. This was a prospective 1-to-1 crossover design. Participants were randomized to eat one of 2 diets, either what we call general healthful diet, which was 20 to 30% of calories from fat to mirror what's given in the general population, or to have the classic high-fat CF legacy diet, and our threshold for that was greater than 40% of calories from fat. So we did not provide the food for participants, but we did provide them with education delivered by a dietitian prior to consuming each of these diets for 7 days. We checked their adherence to the diet through getting 3-day diet records on each diet. We also got a 3-day diet record at baseline just to get an idea of what these people were eating in general before they received any nutrition education. And prior to consuming each diet, we took blood samples, and then after 7 days on the diet, participants came back and had 0-hour and 6-hour blood samples taken to assess modulator concentrations of ETI. We were also able to get a DEXA scan at the baseline visit just to do some exploratory analysis around drug concentration and body composition, as well as dietary intake at baseline and body composition. And at the baseline visit, we also had participants do a qualitative interview. I really enjoy doing mixed methods research, and I find that doing interviews and focus groups really allows us to bring patient perspective and patient voice into the work that we're doing. It's a way that we can help our participants be seen, heard, and understand their unique experiences. So we recruited from the University of Alabama at Birmingham Adult CF Clinic. We had some optional participants come in through the Southeastern Research Cooperative. And each of our 10 participants that participated in the pilot and feasibility arm of this study were from UAB. Our inclusion criteria was that patients be 21 years of age or older, taking ETI, and our exclusion was pregnant people, people with CF-related liver disease, anyone who was listed for or received a solid organ transplant, or taking medications like corticosteroids that could impact metabolism and appetite. For our analyses, when we got the interview data, we conducted inductive thematic analysis. So we had our transcripts coded by 2 independent coders, and intercoder agreement was achieved by merging the code books from the first 5 transcripts to form a unified code book, and any disagreements around coding were discussed between the coders until consensus was achieved. And this data was analyzed with in vivo 12. For the pilot pharmacokinetic portion of this study, paired t-tests for comparison between dietary groups were used, as well as one-way ANOVA when multiple comparisons were needed. And we used Pearson correlations to determine relationships between dietary intake and body composition. And analyses were performed with GraphPad Prism version 10. So this is our baseline demographic data for the 10 participants that we enrolled for the pilot pharmacokinetic arm of the study. Participants on average were 30 years of age with an age range of 22 to 53. 50% of participants were female, 80% were white. We had 50% that were Delta F508 homozygous, and the mean BMI at baseline was 24.5, so our participants were on the higher end of normal. And we also collected this body composition data that is listed here, and I see that there is a typo that did not get updated on the visceral adipose tissue. That should be grams, or have the decimal point moved to before the 3, if in kilograms. And our visceral adipose tissue measures were consistent with other studies of people with CF. So for feasibility data, overwhelmingly participants found this study to be feasible and accessible to them. We were able to meet our recruitment goal and complete the study in the time period that we set out to. And we were able to retain all 10 of our patients. The one issue that we had adherence with is that only one participant did not turn in a diet record for the high-fat diet. So there should be an asterisk next to adherent to diet education. We can't really fully tell how adherent that participant was because we don't have their high-fat diet record to check. But on the whole, participants were able to significantly increase their percentage of calories from fat consumed between the general healthful and the high-fat diet. 6 out of 10 participants were able to meet the exact fat threshold provided for the general healthful diet, whereas only 3 were able to meet the greater than 40% of calories from fat for the high-fat legacy CF diet, but all participants increased their percentage of calories from fat by at least 5%, which shows that they made an effort to adhere to the diets, even if it wasn't perfect. So as we expected, BMI didn't change over the course of our study. This was a very short-term study, and they consumed each diet only for 7 days. We wouldn't expect to see profound weight or BMI changes in that period of time. And when we analyzed the PK data, we found that consuming a high-fat diet did not significantly impact concentrations of elexacaftor, tezacaftor, or ivacaftor, and these were all analyzed separately. So this was encouraging. This means that participants can consume, at least from the small pilot data, a healthful diet that is in line with general population recommendations and still have equivalent absorption of their drug. We also did this exploratory analysis with our body composition data and dietary intake, as well as modulator absorption. And we found some non-significant correlations that might indicate a signal in a larger sample size, but there was a positive correlation between fat mass and dietary carbohydrate intake. And I will shift gears now for the remainder of my time and talk about our interview results. And so these interview results are going to be a little bit wordier, and I have some quotes to share from participants that I'll read. In an ideal world, we would be able to play the recordings or let you hear yourself from the participants, but we did destroy all the recordings after transcriptions in line with our ethics requirements. So 3 key themes emerged in our interviews. These were finding balance with nutrition, a new normal, changing body perceptions, and working together to manage diet and nutrition. Interview questions were open-ended and semi-structured and asked participants about their knowledge, attitudes, and perceptions around their dietary changes that they'd made on modulators and how their body image had shifted. So in our first theme, finding balance, we had 2 sub-themes emerge. The first was diet and nutrition prior to ETI. Participants discussed consuming a high-energy, high-protein diet prior to ETI, what their goals being vastly different, many of them having goals of weight gain as opposed to weight maintenance, and all of the different strategies they undertook to meet these nutrition and dietary goals. Second sub-theme was finding a reason for change and the impact of ETI on their diet and nutrition. Participants in this sub-theme described their nutrition challenges as well as their successes and their perception of what the ideal legacy CF diet was. And there were so many quotes, and they're all really incredible to read, but I just picked one that summed up this theme. And I think it's trying to figure out the balance. Before it was a high calorie, high fat. Now it's making sure I slow down, have a balance, which still to this day I'm working on. It's still a challenge. And we felt like this really reflected the common struggle in our participants to be aware they need to make changes and find more of a balance, but sort of struggling to do so. So our second theme was around changing body perceptions. Again, we had 2 sub-themes. One was on appraising oneself, or body image, and ETI. Participants here discussed their comfort level with their body image, how their body image had changed in response to taking this drug and weight gain, as well as lifestyle changes that they'd made in response to a shifting body image. Interestingly, 6 out of 10 of our participants expressed positive sentiment towards how their body image had shifted on ETI. And this speaks to the fact that many of them had goals of weight gain before taking this drug and were finally able to do so and felt better in their skin, being finally able to achieve their long-term nutrition goals. Participants that were expressing negative sentiment around their body image, when we linked them back to their anthropometric data, tended to be the participants that had higher baseline BMIs and did not have a goal of weight gain prior to starting modulators. And then our second sub-theme was weighing in, perceptions of weight. Participants here discussed their comfort level with weight, what their goals were before and after taking ETI, and their reaction to weight changes. And again, I could pick lots of quotes, but I went with this one. Immediately after, I would say it was poor body image, but since then, the positive side would be gaining muscle, and that's something that I worked really hard for years, so it was really cool to see that finally happening. What was most striking to me about the work that emerged from this theme was the spectrum of how people felt about their body image, and it really highlights that this is something that is deeply personal to our patients and families and something that's worth exploring and not a thing that we can make assumptions about. And finally, our third theme was around working together with the care team to manage diet and nutrition. We had 4 sub-themes here. One was discussing diet and nutrition. This was sort of how should the team bring it up, who on the team should bring it up, how to improve this conversation, and how teams can best support their patients. What will be surprising to probably nobody in this room is that patients far and away thought that the members of the care team who should bring up any weight changes that needed to occur were the physician, the dietitian, and the social worker. But many of them did say that it should be a whole team effort. So our second subtheme was proposing a change. Participants here discussed the team recommended diet and nutrition changes that they had been encouraged to make, and if they felt like this was feasible. Our third subtheme was perception of nutrition convos, and these were positive perceptions, overwhelmingly. None of our participants expressed a negative sentiment around the conversations that they had been having with their clinicians around nutrition and body image in the clinic since being on ETI. And finally, we had a question about resource requests, and participants had various different requests. They all sort of fell under the bucket of wanting diet, food, and recipe resources, but every participant had sort of a different slant on what resource would be helpful to them. Again, this drives home to me that care has to be highly, highly individualized. And so my final quote is one participant who said, "I think just having an open mind and being very understanding and not judgmental, because nobody's perfect. And a lot of this can be a lot to juggle, and everyone has their own stuff going on in their own lives. I think just really the level of compassion and being understanding, I think that's the biggest things one can do." And this is a good reminder to me and everyone else who works with patients that we need to listen without judgment and show compassion and empathy, especially when discussing sensitive topics of rapid modulator weight gain and body image issues. So our study did have limitations. Obviously, this was a pilot and feasibility study, wasn't powered to detect statistical differences, and was more an exploratory analysis for hypothesis generation. And along those lines, we had a small sample size. This was also a single center study. But in conclusion, our study was feasible and acceptable to our participants. Opportunities exist for deepening partnerships with CF care teams and patients around providing personalized nutritional counseling and support to people with CF in navigating diet and body image changes. Consuming a high-fat diet did not significantly impact ETI plasma concentrations, and all participants were in range for clinical effectiveness of ETI regardless of their fat intake. And finally, our future directions. There is a need for continued exploration of the lived experience of people with CF related to their body image, weight management, and dietary changes in relation to modulator use. I think that this is something we're all hearing anecdotally in clinic, but there just needs to be more research to really bring the patient voice into these interventions that we're designing. We also need to clarify diet composition for optimal ETI exposure for people on CF with this therapy. I know many people want to know what the lowest fat level is that this drug can still be absorbed. Our study is not able to tell us that, but hopefully larger prospective studies can be designed to give us that information. And then I wanted to acknowledge my team from UAB, the participants who generously gave their time to be a part of this study, and specifically wanted to shout out again to Dr. Gimbalot and to Dr. Natalie Rose, a postdoctoral fellow who did a ton of analysis on this and helped put together our slide decks for us. So with that, I'll take questions.
Okay, we do have an app for questions. So Ellie Jobst, I'm so sorry if I messed that up, has a question for you. Did you look at any correlations between fat mass and the specific type of carbohydrate intake in your study?
No. That would be great for a larger study, and that's a great idea for going forward with this work, but we did not look at specific carbs.
Dr. Ziegler?
Tom Ziegler, Emory University. Dr. Bailey, great talk. If I did my calculations right, the amount of extra fat that's recommended for the new therapies is about 180 calories a day. So that's like, what, I might be wrong, 15 pounds over 10 months. Does that sound about right? And then In your study, the diet, did you alter, I missed it, did you alter the fat content? So were you giving quote unquote healthy fat recommendations and stuff?
We gave some general diet education about eating healthier fats. We did focus heavily in the education about the specific amount of fat to eat on each diet. We provided the range, like the percentage of calories from fat, and then we were able to use the baseline diet records and diet recalls to determine their typical level of intake and then give them fat gram amounts to aim for while they followed the diet.
Hi, Dr. Bailey.
Hi, Kim.
Did you alter the amount of fat the patients were taking with their ETI at all? So once you have the diet records?
We didn't alter the amount of fat they were taking with the ETIs specifically. We asked them just to take it with a fat-containing food. We were more focused on their total diet pattern rather than trying to pair exactly the fat at the time of consumption. That makes sense.
I've got a question, or maybe a thought. So were people not eating the recommended amount of fat before?
I really like this question, and I would like for you to come to my workshop presentation in the morning where we're going to go through in detail the results from the diet record analysis and how diet quality and composition changed after nutrition education on each of the diet patterns. Sorry to make you wait. And it's now my great pleasure to reintroduce Dr. Jessica Alvarez, Associate Professor at Emory University School of Medicine. Jessica, we can't wait to hear your presentation.
All right. Okay, so Doctors Foligno and Bailey perfectly set up this talk as if we'd planned it. I am going to focus on CF-related diabetes today. Disclosure. Really the goal of this one is to summarize published and ongoing nutrition research related to CF diabetes. So you've seen this. This is from the 2023 CFF patient registry highlights. It's a beautiful figure. We know this. We've heard this today and throughout that highly effective modulator therapy has really changed the course of nutrition for people with CF. So decreased malabsorption, undernutrition, both in children and adults, shifting over to increased prevalence of overweight and obesity. I wanted to highlight these numbers here. Let's see, can I do that from here? Can you guys see that? Yeah. So the overall prevalence shift in pediatrics from overweight and obesity has gone from 10% in 2003 to, 21% in 2023. And among adults, this one has gone from 18% to 42% overweight obesity. And these are the most recent CFF registry data. We've also seen changes in the CF age demographics. 1999, when I graduated high school, the median survival span was 33 years, and it's now 61 years of age. So we are now seeing, we're in a place where there are more adults with cystic fibrosis than kids with cystic fibrosis. So we can no longer consider this a childhood disease. You guys know this, though. I love this slide. So we're now in this space where we are living longer with CF, but in the obesogenic environment that the general population has also been dealing with. So it's sort of an out of the frying pan and into the oven situation, because not only is our CF population aging and having to deal with the metabolic diseases that come with that, but also you are dealing with chronic disease of cystic fibrosis, again, in an obesogenic environment. And we're seeing increased prevalence of adult disease in CF. And so they're listed here: diabetes, bone disease, colorectal cancer. And we haven't seen increased cardiovascular risk yet, but there's some evidence of vascular dysfunction and hyperlipidemia. In the general population, related diseases are known to be influenced by nutrition, and nutritional interventions can mitigate these risks. Are they amenable in our CF population? I think so. So this talk, as I said, will focus on CF-related diabetes. A little background. CFRD is its own clinical entity. It is distinct from type 1 and type 2 diabetes. It does have some elements of both. Very high prevalence by middle age. There's almost a 45 to 50% prevalence of having CF-related diabetes. And this is important. It lowers the quality of life, accelerates lung function decline, and overall increases morbidity and mortality. Historically, CFRD was associated with undernutrition, and you would see this accelerated decline in BMI and body weight before a diagnosis of CF. And so treatment was with insulin provision, with continued dietary focus on ensuring high-calorie, high-fat intake, which we needed, which our patients needed. However, work out of Montreal has shown that suggested that there's no longer this apparent accelerated decline in nutrition status before a diagnosis of CF-related diabetes. And this is showing you just the trajectory weights of BMI among different groups. No difference between normal glucose tolerance or CF-related diabetes before a diagnosis. The primary defect in CF-related diabetes is a reduced and delayed insulin response to glucose. And this here shows a graph of some work that we did looking at insulin secretion rates following an oral glucose tolerance test. And so our healthy controls are these purple and orange lines where you see a sudden increase in insulin secretion and it goes down, right? But if you look here, this blue line, even in people with CF and normal glucose tolerance, you see that decreased insulin response to an OGTT compared to this. This is normal glucose tolerant CF. It gets worse as people progress to diabetes and CF-related diabetes, or to prediabetes and CFRD. So older studies predominantly attributed insulin resistance to increased inflammation and insulin needs during illness in CF, but it was not a big part of a CF-related diabetes diagnosis. Now, again, studies out of Montreal have shown that CFRD develops from a combination of insulin secretion and defects and insulin resistance. And insulin resistance has been emerging with increased age and overweight in our CF population. Big slide. This is just meant to be a snapshot for you. I'm not going to go through these, I promise. Recent work has suggested that there may be improvements in glycemia and outcomes with highly effective modulator therapy in people with CF. But if you were to take a snapshot of this and look, the improvements do not occur in everyone. It may depend on what your pancreatic status was before you started taking modulators. So a big point of this slide is highly effective modulator therapy may not improve outcomes in all. And we also have to consider that not everyone is eligible for highly effective modulator therapy. So there's a lot of variability in outcomes here. So we need to continue to think about other factors that are contributing to or that mitigate CF-related diabetes risk. So I know there was a recent tea time session with Dr. Vintang Pricha and thinking about vitamin D. So in recent studies, this was a meta-analysis, this first bullet point here, suggested that in people without CF, but with prediabetes, vitamin D supplementation may decrease the risk for overt diabetes. And so we have looked at that over the years with Dr. Tampricha. In 2021, we published a retrospective chart review in adults with CF at Emory that showed that there was less time to develop CF-related diabetes in those who had a 25 hydroxyvitamin D level, less than 20 nanograms per mil, compared to those who had sufficient levels. And that's shown here. We've also, with Dr. Tampricha, looked at secondary analyses of his famous DISC study. This was in hospitalized adults with CF. We didn't see an effect of high-dose vitamin D supplementation on any of our glycemic outcomes, but the verdict is still out. Regardless of this finding or any of our findings, we still want to continue to promote adequate vitamin D status in our participants, in our population. So we know excess adiposity contributes to glucose intolerance in people without CF, and this is especially visceral fat. This leads to insulin resistance, which I just talked about, insulinemia, and then over type 2 diabetes and cardiometabolic disease. And this is often mediated by excess free fatty acids, excess inflammation, oxidative stress. We have been looking at this in my lab, the role of visceral fat in adults with CF on chronic disease. This is a study done by now a postdoc registered dietitian, Mariah Bellissimo, who we found significantly higher visceral adipose tissue in people with CF compared to healthy controls. And these were age matched, despite the fact that they had similar BMI, similar lean mass, and similar fat mass. When we looked at the relationships of visceral adipose tissue with glucose homeostasis, we showed, this is only among the people with CF, we showed significantly increased fasting glucose with higher visceral adipose tissue levels. And we saw this with measures of insulin resistance as well. These are fasted measures of insulin resistance and fasted glucose. In a separate study, our Orbit CF study, which is ongoing, we found similar results, and this time it was with whole body insulin sensitivity. So insulin sensitivity measured following an oral glucose tolerance test. Again, we found with higher body fat and higher visceral adipose tissue, there was decreased insulin sensitivity in our adults with CF. So there was a question earlier about diet quality. We have looked at diet quality in adults with CF, and we found that despite no differences in overall macronutrient percentage, so percent carbs, percent fat, those were similar between our groups, our adults with CF had significantly higher added sugar intake, higher glycemic load, lower fiber, higher saturated fat, trans fat, and overall a lower healthy eating index compared to our controls. And so how did this relate back to visceral fat? We actually did show a significant positive relationship between added sugar intake and visceral adipose tissue in our participants with CF. We actually showed that when we statistically adjusted for that difference in added sugar intake, we no longer saw the difference in visceral adipose tissue between our participants, suggesting added sugar intake could be a mediating factor in these fat distribution differences. So Dr. Tanis Jadali, a pediatric endocrinologist on our team, also dug a little bit closer on diet quality and glucose tolerance outcomes. And she showed that higher intake of monounsaturated and polyunsaturated fatty acids was associated with greater insulin secretion as measured by HOMA-2B here, which is a fasted measure index of insulin secretion. She also showed that higher added sugar intake was associated with decreased insulin sensitivity, this HOMA-2SB. And this was different and something that we want to dig in a little bit more, but higher consumption of plant protein was positively associated with insulin sensitivity. So other studies have published on diet quality and glycemic outcomes. This was a very small, not many studies to date, but this was a small study that looked at continuous glucose monitoring and food records, and they found that higher dietary glycemic load was associated with worse outcomes using CGM as the endpoints. They didn't find any relationships with dietary fat or protein. I know I've only been able to see one published study looking at an actual dietary intervention. What I've shown before is cross-sectional. So this was a pilot study published in 2020, and it was a behavioral intervention using pamphlets and foodlets for 3 months, looking at a low glycemic index versus standard CF diet. And while they didn't find anything statistically significant, over these 3 months, they did find a trend, it was close, towards improving fasting glucose among those who were randomized to the low glycemic index intervention. So before the pandemic hit, the Academy, I love to say that, they convened a group of wonderful dietitians to look at the literature, to systematically review what was available, again, pre-pandemic, what was available in the literature so that we could come up with updated evidence-based practice guidelines. And for the first time, we addressed diet quality in our guidelines, which was very exciting. So we emphasize foods with positive health outcomes that are associated in the general population. Of course, supplement is needed. We emphasize dietary patterns that promote consumption of nutrient-dense foods, including healthy fats and micronutrients. For those not at risk of malnutrition, we suggested that macronutrients should be the same macronutrient distribution as recommended for the general age population, for those not at risk of malnutrition, of course. And for CF-related diabetes, we emphasize limiting high sugar foods and beverages with low nutrient density. Whoa. But when you look at the grade, so we want to see, super high grade confidence in our recommendations, we had to go with a consensus base grade because there simply was not enough data to give us the confidence to do these. So these are consensus based. So now I just want to tell you a little bit about a study. Given all of the results that I told you, we used all of that as preliminary data to finally get grant funding after a really long time for an actual dietary intervention. We call it the Feed CF study. And here we're testing the hypothesis that high added sugar intake will promote beta cell dysfunction and insulin resistance, and that it'll promote visceral fat and ectopic fat distribution. And we're also testing to see if oxidative stress is a mechanism, plays a role in some of those mechanisms here. Large group of folks on the team, including folks sitting here and at the meeting in general. I don't think I have time to really go through this slide, but if you're interested in learning more specifics about the study, please go see Dr. Swati Zavaria, poster number 631. But really what I just wanted to show you was hopefully what's coming. And so we're hoping to recruit 60 people, 30 will be randomized to a low added sugar, high fat diet, another 30 to the standard high added sugar, high fat, typical CF diet meals. It's an 8-week study. All foods will be provided, so we mail the foods to participants. That's been fun to figure out. We have them coming in to do oral glucose tolerance tests and indirect calorimetry so that we can figure out how many calories to feed them, continuous blood glucose monitoring, MRIs to really assess visceral fat as well as thigh fat. We're using gold standard measure of beta cell function, which is a glucose potentiated arginine stimulation test, and then looking at plasma redox. So stay tuned. It might be a few years before we can finish all the 60. Just to summarize, new therapies have changed the course of cystic fibrosis. This is a wonderful thing. CF is no longer a childhood disease. However, comorbidities associated with aging will continue to increase. So we need to consider how to manage the comorbidities in this aging CF population. And you've heard talks today and elsewhere that we're really thinking about this. Highly effective modulator therapy effects on CFRD risk are variable. So we really need to understand other factors that are contributing to CF-related diabetes. Diet plays a critical role in risk mitigation and management of other forms of diabetes. And we have at least cross-sectional evidence suggesting that poor diet quality is associated with CF-related outcomes. Ultimately, rigorous interventions are really needed to determine the role of nutrition on improving CFRD risk and management, and that's what we'll be able to use to ultimately develop evidence-based guidelines in this era. So with that, I'd like to acknowledge our A to Z lab, as we call it, which has grown significantly, and our extended A to Z family, our external collaborators, including Dr. Stalling sitting right here, my idol, and our funding support. And of course, our study participants. So, all right, I think we should have time for questions.
And we'll have Dr. Foligno come back up. Is this on? Can you all hear me? Yes. Yeah. Be really close to it. Okay. So, Jessica, we have one question in the app for you, I believe. It's, do you know if any studies looked at the impact of higher fiber intake on glycemic outcomes?
I know that data is available in the general population. I have not seen that in a CF population. I think that would be really great to study and something that I think a lot of folks have food record information for and can go back and do some analyses.
Thank you so much for excellent presentation. I'm Senthil Sankaraman from Cleveland. So in the study by Dr. Tangprika, it's clear that patients with vitamin D deficiency they are associated with increased risk of CF-related diabetes. Is there any data to suggest or to show that keeping the vitamin D a little higher, like say between 30 to 40, optimize the vitamin D levels to further mitigate the risk of CFRD?
So that's a great question. Thank you. So, just to repeat the question, I hope I get this right. The question was whether going even higher with vitamin 25 hydroxy vitamin D levels will further mitigate the risk for vitamin D. In that retrospective analysis that I showed you, we looked at cutoffs, different cutoffs. So we looked at that standard cutoff of 30, above and below 30, and we didn't find any differences. It was when we went to the lower cutoff of 20 that we found those differences in CFRD risk.
Thank you.
Thank you.
Thank you so much for your talk. I'm Erin Scallern, dietitian at McLean Children's in Temple Tech. Okay. Do I keep talking? Okay. I was curious if y'all are somehow controlling for the risk we see in like non-CF patients where malnutrition is associated with type 2 diabetes and insulin resistance later in life. So as a child, if you've experienced malnutrition, then as an adult, we're seeing that correlation. That would seem very, very relevant and hard to kind of tease out as you're studying this population.
Yeah, that is a great point that I hadn't considered, but you're right about the risk of malnutrition in childhood leading to older diseases. That's not information that we're collecting, like what things were like in childhood, but that's a really great point to consider.
I mean, just as we're systematically considering weight bias and things like that, that might be something nice to kind of add in as we look at it, and assuming it's, as opposed to assuming it's all about the excess adipose tissue.
Right, that catch-up growth is really important early on. Thank you.
I'll echo, that was a great question.
That really was.
Jananne Stallings from CHOP. You know, I hadn't thought about we're a medical model of the Barker hypothesis, and most of our babies are born full term and normal weight, but then they go through a period. So that's interesting. Part of what struck me today about the session one, when you were presenting the behavioral therapy, and I was there with Dr. Hummel and Stark, and we spent all of us time and energy on great behavioral programs and got modest changes of weight gain. And now we're having intensive behavioral programs and getting modest changes in weight loss. And I agree, we're going to have to just keep thinking about that. And the whiplash of the people that you're studying now grew up when we were just really beginning to focus so much of let's get you on the growth curve and all that. The only data question, and I may not have heard it right, but you're how are we going to talk about fat in the diet patterns? So what is percent of calories as fat, which we know a good bit about epidemiologically and how to make that heart healthy and, you know, all of that. But it's a lot harder to talk about grams of fat. And I would encourage us, I mean, you need to know about it, but not think about it so much because it's just a different way. And people shouldn't be eating less than 20% fat. And you've still got CF, and the modulators don't change the malabsorption. So if you get lower and lower fat, then you risk all sorts of other things. And heart healthy tends to go up to about 30% of calories as fat. in the general, general population. So all of what you're doing is going to be very interesting about how do we start to talk about growing a next generation of people with CF, just to be, even as you said, we don't have a lot of heart attacks yet, but we could, but how to have that concept of heart healthy fat. And I was surprised there was so much trans fatty acids in whatever data point that was.
Yeah, our population tended to eat a lot of processed foods. I think we're in the South. You're right.
I'd just like to comment on Dr. Stallings, your message, and I know you've been really aware of some of the work that Dr. Powers and Dr. Stark and I have done. And in our non-CF study, in our pediatric obesity study that I had on our slide, these were preschool kids. And so again, we took a really thoughtful approach to recruitment, because this is a lot of the families that we recruited had not had this conversation with their pediatrician. So they were kind of surprised to get invited to the study, because from a weight and BMI standpoint, their percentiles were in that overweight range, and a lot of them hadn't had that discussion with their pediatrician. In our first visit with these families, we showed them like kind of how far away they were from a healthy weight percentile, and we had calculated sort of what it would take to get there. And we had a do nothing, we had like a weight maintenance trajectory, and then we had a weight loss trajectory. And we didn't have any families choose the weight loss trajectory. They all selected, how can we just maintain where they're at now for weight, have them continue to grow in height, grow tall, and sort of just settle out. And I'm not sure that that's not what we're probably going to be hearing from our families in CF as well. So just a point to put out there.
It's for you, Dr. Foligno.
Mm-hmm.
What do you think? Sorry. These mics are really tricky. Is this better? You have to
Yeah.
be right on it. It's so awkward to not look at you when I'm talking. But what do you think is the sweet spot as far as intervention frequency with the behavioral interventions around nutrition?
What we know from strong methodological studies of any behavioral intervention for any target, any health target, is they need to be more intense in the beginning. And so depending on the feasibility and what families want to do, I think we could meet with families weekly, because the reality is so much changes within these family systems from a day-to-day basis that in order to actually build that relationship with the family, if you don't have it in place already, know what their goals, their values, their barriers are, and then identify what's the right metric that you're targeting, and then be able to help them problem solve in those first few weeks. I think we can absolutely space things out, but the reality is we're making our best guess about how long and how intense these interventions should be based on existing literature. And so I think it depends, but we shouldn't stop until we see change. We should keep going. And then we also, the part B of that is what is the right frequency and the right timing of that follow-up care that people need to maintain those gains. I hope that's clear.
Yes.
And not clear as mud.
Thank you so much for that answer. I think this is something that as a clinician researcher, I think about a lot, that most of us are only getting to see our patients in clinic once every 3 months for half an hour at best, and that to actually make meaningful behavioral changes, we're going to need to adjust our care model to reflect something that's similar to what you're talking about, and we're going to have to think about things differently.
Yeah, and this is where I will absolutely put a plug out there for us to be creative in our utilization of telemedicine approaches. Of all of the pitfalls and landmines that COVID created for us, one of the blessings of it was we got shook up and we started using telemedicine more when we should have been using it for a really long time. But we understand the barriers with paying and, getting reimbursed and state line licensing and those sorts of things. But I will tell you, I am doing so much telemedicine follow-up with our CF population at Cincinnati Children's, our population. I'm seeing probably more kids through telemedicine now for follow-up behavioral intervention, psychotherapy intervention than I am in clinic probably. And so I felt that angst, just like you're describing, is behavior change is not going to happen when you see someone every 3 months. That's not going to happen. And it's sort of disheartening because it's possible to see the change and partner with people. So let's really keep advocating for a proper and effective and powerful use of telemedicine approaches.
There's been a lot of discussion at this meeting on healthy diet, healthy fats. So I'm going to have a challenge for the room and for the panel. And just to follow up on Janine Stallings' comment, do we know much in this current era of modulator therapy about essential fatty acid deficiency, essential fatty acid excess? Because linoleic acid can be a very pro-inflammatory. So about that, and then how should we as the nutrition community interested in research in nutrition and CF go forward with regard to monitoring, maybe Dr. Stallings can have some suggestions, monitoring fatty acid status in our patients as we change to a more healthy fat diet and we compare those people who are unable to do that. Cell membranes, et cetera, et cetera.
I'll start. I think this is kind of a complex question. So there's a lot of history on essential fatty acid deficiency in people with CF. It looked like, if I remember correctly, and a lot of you in the room will know more than I do, supplementing with fatty acid deficiency wasn't really the cure that we thought it would be. But that being said, I don't have a current gauge of what essential fatty acid status looks like. So I would love to hear from someone now, in this HEMT era, on that. But I will say, just to address the second one, the overconsumption of linoleic acid and its pro-inflammatory effects, is that those are also foods found in low-quality, high-processed foods. And so a lot of, in this obesogenic environment, we are exposed to high linoleic acid, low omega-3 fatty acids, along with everything else that comes in highly processed foods. And
What is the cost of the panel in the States? What is the cost of the panel in the States? Do you happen to know if it's reimbursed by insurance or if people's health coverage?
In CF, just like our once-a-year vitamin A and vitamin D, it would be.
Very good. Thank you so much, Dr. Stallings. It's always a pleasure to hear from you. I see we have one more question or
Do
comment.
you have time for?
Yeah.
This has been a great session, and I'm particularly pleased that we're beginning to talk about how can we do something about the issue. I think there's an urgency to have better outcomes for children's body composition, weight, and there's a number of reasons. And we haven't talked about very much the relationship between these things and lung function, but we do know that fat tissue creates inflammatory mediators that may increase resistance to airflow. But there are some studies now that are showing that there is a condition called dysynapsis that occurs in children with obesity. And dysynapsis is really a disproportionate growth of the lungs compared with the airways. So the airways are relatively smaller, And in the adult literature now, there are many studies on the relationship of dysynapsis with chronic obstructive lung disease appearing early, like in the 20s and 30s. I think that's going to happen with some of our CF patients too. So what I would plead for is work that figures out how can we better help children not reverse problems with obesity, but in fact prevent adverse kinds of both weight gain and body composition. So I am not going to be a part of the group that makes that happen, but I would challenge all of you to figure out, because I think it is going to be important for the lifetime of the people with CF now.
Thank you, Dr. Boat, for those comments. I think we can learn a lot from the asthma literature regarding obesity, but I agree, preventing is going to be the key. With that, it is 2:00 and we've kept you as long as we can possibly keep you. Thank you so much.